So welcome to the people who have come now, and welcome to the first session on this stage. Welcome to session 1B, called Health Moonshots, Future Opportunities and Challenges in Medicine. Before we start with the keynote, I would like to introduce Laura Wamprecht as the session moderator. Mrs. Wamprecht herself is the managing director at Flying Health, the leading ecosystem for next generation healthcare, and she will guide you through this session. So I'm looking forward to our first session on the stage, and yeah, the stage is yours.
Thank you so much for the introduction. So I think we had the perfect session after the opening, so where we had the topics of does healthcare need a trip to Mars or reaching the stars? And it's my pleasure to directly introduce our first keynote speaker. Welcome here at the stage, Robert Percy Marsha. You're the team doctor of RB Leipzig, so you're working since many years with high-performance sports teams, and we are looking forward to what is your Moonshot project here today.
Yes. Thank you very much for your kind introduction. Hello, everyone. Nice meeting you. First question, the slide that I see down here is always the one that you see as well. Can you see anything yet? Can you see anything on the screen? So it's only me that I can... Okay, perfect. So I have 20 minutes to tell you how to stay healthy and what guidelines, what recommendations I can give you from my work with professional athletes. As you can understand, 20 minutes is quite short, so it only gives me an opportunity to give you some slight hints, and I would like to start different than I would usually do this. So usually I would introduce myself, telling you where I come from, but this is not how I would like to start today. So what I would like to aim for is to ask you who you are, and if you know who you will be in the future. And because this talk is about you, about giving you information and guidelines for the future. So since I don't know you, I will just guess. Statistically, we've talked about statistics, we have now talked about, or we've heard about information. So let me just take a few guesses. So you most likely have slept less than 7 hours the past night. Whereas when you were a child, this has been 14 hours. You were a small child. And as a teenager, you probably gave your parents a hard time because you preferred to sleep at least 10 to 11 hours. And only, if you look around you, only about 2 people reach the expected 7 to 8 hours that are recommended on a healthy basis. And looking at the picture, if you ask yourself, why am I showing you my dog? Well, dogs actually sleep up to 18 hours, which is not healthy for humans. As of 10:20, you probably walked less than 2,000 steps. And it's very doubtful that you will double this today. Most Germans don't walk more than 5,000 steps. And actually, only 2 that sit around you will reach the recommended physical activity level. 90% of our daily life we spend indoors. On average, a German is on sick leave around 18 days a year. In 2006, so this is 18 years ago, it was still 6 days less. And every second German is at least once a year not able to work. And nearly every one of you will feel stressed at least once within the next month. And this is actually quite shocking what I would like to show you now. So during my talk, at least most of you will probably look at least once on your smartphone, because everyone, on average, will look every 20 minutes on their smartphone. In total, today, it will be around 80 times. 80. This is around 11 hours that you will usually spend looking on digital screens. That's more than you would look out of the window. Just think of this. Just compare it. Our children actually spend around 2 hours watching TV. I guess probably most of you agree that food must be healthy, and most of you eat fruits and vegetables quite regularly. However, if you're stressed, most of you will try and eat fast food. It's convenient, it's easy to get, it's cheap. In average, you will drink around 108 bottles of beer or 43 bottles of wine, if you're a good German. Counting off my numbers, you will have to drink more. And as of today, you will probably consume 4 times the amount of sugar that is recommended if you want to stay healthy. And if I look around you, or around me, I'd say most of you are aged something around 40. So let's assume you're all 40. This would mean as a woman, you have 47 more years to live, and less, or around 1/3 of this time, you'll be not healthy. You suffer from disabilities. And sorry guys, if you're a man, it's more than 40%, or around 40%, that you will not be healthy. That's why I'm up here. Yeah? That's why I'm talking to you, because we want to change something about this. And it's quite easy to summarize, and that's what we call 4P medicine. So it's preventive, predictive, participative, and personalized medicine. Understanding who is standing in front of me, making it preventive so you have more than the time I showed you, staying healthy, longer time to live, but that doesn't work without you. Yeah, and we want to find out when this happens, before it happens. That's what we call 4P medicine. And that's what we're aiming for, and that's what we actually do on a regular basis in professional sports. So this is what it looks like, actually. We call it the Leipzig way, so it's understanding who we are, it's understanding the cultural origins, the habits, the medical background, then it's nutrition, and then my job starts. Yeah, then it's supplementation, then it's intervention, but it's understanding the risks and the habits of the person in front of me. And since it's about you and not about professional sports, it's about stress. Stress is harmful. Stress is to protect us against the lion that we rarely fight today. So it's protecting us against wounds and bacteria, but making us exposed to virus. And chronic stress makes us sick. And actually this whole hormonal and endocrinological cycle is the reason why we turn sick when we go on holidays. if all these hormones that would usually activate us for the fight, if they drop because we finally really relax, it exposes us to infection and we get sick. But, stress is stress. It doesn't matter. For the body, it doesn't matter if you're fighting a lion, if you have a fight with your boss, or if you just won the German soccer cup. Stress remains stress. Any way you do it, if it's healthy stress, you can adapt. If it's unhealthy stress, it will harm you. And this is what I usually show, because that's how you can picture it. That's what happens to your cells if you get exposed to stress. It's not the healthy apple, it's the black, crumpled, rotten apple. And if you still don't believe me, look at these two guys. So I hope the right one you know. The left one, for anyone who is not as familiar with American history, it's Franklin Roosevelt. Basically picked a time to be the American president that was not the least stressful time. It was during the Second World War. So anyone in your mind, think to yourself or ask yourself, what time period is between those images? And Franklin Roosevelt, actually, it was 10 years, and Barack Obama, it's 7 years. So I believe all of you understand that they haven't smoked heavily, that they were not alcoholics. They just picked a stressful job, probably the most stressful job in the world, and it makes them look old. Yeah, and that the same thing happens to coaches. Yeah, soccer coaches. If you look at pictures of them, they really turn old within a very short time. They age biologically faster than they would age chronologically. And this is how you can picture it. It's a balance. It's a balance between load and regeneration. And if the load is higher than your personal regeneration or than your personal resources, you turn sick. So it's our job either to reduce the load or to fill up your resources. That's what we're aiming for. Because it's about the right amount. If it's too little, you don't get trained. Your system doesn't train itself to be protected. If it's too much, it harms you. So for each of you, for your individual needs, we need to find the right amount. We call this hormesis. And don't be afraid, I will not explain the whole slide here, but on this whole stress level, major influences are psychological stress, the gut, the microbiome, and nutrition. That's what I want to point out. And if you really want to go into detail, that's how we deal with this with our athletes. That's how you can picture regeneration. Yeah, so it's different influence factors like the microbiome, muscle, genetics, energy, and from there you can go further into detail, and it depends on you and upon the resources that you have, how much into the detail you want to get. And each individual has their weaknesses within the system, and that's what we have to define. And that's why it looks like this at our academy, why we have so many different options: infrared sauna, cryosauna, steam sauna, Finnish sauna, pool, active regeneration, supplementation, whirlpool, ice bath, all that kind of stuff. It's because each athlete is different. So it's about strengthening your oxidant defense, because that's what stress ultimately comes out as. It's oxidative stress. So through influencing and changing our diet, doing the right amount of exercise, applying cryotherapy, cold therapy, and using drugs or phytochemicals, we actually strengthen our defense system. On the right upper corner, I showed you, like it's curcumin, ECG is what we have in green tea, resveratrol is what we find in berries, quercetin in onions, caffeine, obviously everyone knows, metformin is a drug. So it's usually, except of metformin, it's usually natural compounds that we can use to strengthen our defense system if we use the right nutrients. It's about breathing, how to breathe properly. And this is a work from 2023 that highlights that even if you only do these workouts 5 minutes a day, you will actually influence your stress level and your anxiety level. So this improves your mood by changing your respiratory rate. And you all probably, if you're familiar with soccer, you know the pal on the right side. Look at soccer players when they start or prepare for a free kick or a penalty kick. They have their habits, the way they walk, the way they breathe. They do this to calm down, to be prepared for the moment. It's cryotherapy, applying cold. It could be a shower in the morning, it could be an ice bath or similar. We use intermittent hypoxic therapy. It's basically simulating being on a mountain. And the most important thing for us, it's nutrition, healthy nutrition. So that means no sugar, whole grains, no industrial wheat, rarely red meat. It's lots of vegetables, lots of fruits, fish, white meat, healthy oils, lots of food, and enough exercise. Obviously our athletes get that quite often. And taking care of your sleep. It's really important. We know from the people that grow, like we call them sanitarians, the oldest people on our planet, they sleep on a regular basis. It doesn't matter for them if it's a weekday or if it's a weekend, and they sleep more than 7 and less than 10 hours. And this is what I want to give you an impression of. It's the interplay between environment, epigenetics, and genetics. It's what you're made from, but it's also what you make from it, because you influence this. You are not only DNA. 20 to 40% is what's programmed, the rest is what you make from it, and how you influence this. That's what this shows. So you can prevent through adapting your lifestyle. That's how you can understand this. It's about prevention and intervention, when to start and how to stay healthy. Use exercise. It's more than 150 minutes a week. Exercise will influence your whole body on an optimum basis. And last, what I would like to give you, if we're talking about mobile phones, smartphones, understand the power of nature. It's if you stay inside running and you go outside for a walk or for a run, it doesn't make a difference. We know that people in cities are more depressed. We know that nature actually activates and inactivates certain areas of our brain that calms us down and that deactivates stress. So nature actually keeps us healthy. The Japanese culture calls this Shinrin-yoku. So go outside without your mobile phone, without a podcast on your phone. Don't work out regarding any plans. Just do it. Go outside. Feel the nature. Feel the air. Feel your body. Breathe, sweat, and enjoy this. And if everything works together, it's a very complex interplay. That's what we are for, to explain it to you. Understand that there is no one way. It's understanding which way is the right for you. And if this works out, then we are quite happy. Is there sound on the video? I'm sorry.
Ist ganz bitter, es gibt die rote Karte.
Ich kriege Gänsehaut überall am ganzen Körper, wenn ich daran denke und die Bilder sehe.
And if everything works together, I can tell you, if you're a football fan or not, it feels great to reach something and to see how works can be put in action. But if you look at this at a smaller scale within yourself, it's great to do something good. So I can just encourage you to do so. I want to thank you for listening to me, and if you have any questions, either talk to me after the talk or use my email or contact me via LinkedIn. Thank you.
Thank you very much for first showing us how average we are. And I was counting everything more or less, so yes, probably true. And on the other side, I was wondering if this is the nature stage, because we have some sunlight and we have trees. So we are getting closer, at least coming from the opening session in the other room. So thank you so much for opening the session, and we will have you back on the discussion later on. So my next speaker here is Dorothea. You're a professor for nutrition-based medicine, so I was looking at you and when he was talking about the nutrition facts, so I'm wondering if you agree with most of the statements or if you have a different opinion. So you're a professor at the SHR School of Healthcare, and I'm looking forward to hear your talk.
Yeah, thank you very much. You hear me? Yeah. Thank you very much for the introduction, and yes, I would like actually to give an input on a diseased state, and thank you to Robert to give us a general overview what is important for our health, but what happens when our health is already altered, so when we are speaking about obesity. And let me start by asking you the question, what do you think is a healthy weight? Well, you can see here a statue 11 centimeters, crafted over 30,000 years ago. So, and this statue, do you know the name of it? It's the Venus of Willendorf. And she actually embodies, she's well nourished, has wide hips and breasts, and she embodies a symbol of fertility. A woman which is able to bear a lot of children. But our times has changed, and this is now our ideal of body weight. But how the reality looks like, and indeed, and this was already addressed before, the reality looks quite different. We are snacking around, we are just lying around, our kids playing PlayStation and drinking soft drinks. And we are suffering from back pain. We are not moving. So, and by the way, musculoskeletal diseases remain the most common reason for work absence. So we are stressed and we are constantly on our phone, on social media. And it's recapitulated by the numbers. Obesity is a problem. And yes, we have a pandemic. And these are numbers from 2019, and over half of the population in Europe is overweight. 36% are pre-obese and 70% are obese. And the numbers are not different in our children. Almost a quarter of our children is overweight, and the numbers still continue to rise. But what we can do about that, and why is it too difficult to maintain health and maintain a healthy weight. So let me start by giving you a short background about the physiology. And I will continue actually from the first presentation. And obesity is not appearing from one day to the other. It's a chronic disease. It's slowly progressing. And the adipose tissue, it's expanding slowly. And with adipose tissue expansion, in particular the visceral adipose tissue, so meaning the belly fat, the inflammatory milieu of the body is also increasing. So inflammatory cells accumulating within the adipose tissue and triggering the release of pro-inflammatory cytokines. And these cytokines triggering then the development of other comorbidities like high blood pressure, type 2 diabetes, arthritis, and so on. But are there any therapeutic options? And yes, we have these therapeutic options. And along the German Society for Obesity, where I'm also a medical advisor, we have these building blocks: the conservative therapy, conjunctive pharmacotherapy, and bariatric surgery. In particular, the conservative therapy consists of nutrition, exercise, and behavior. Recently, we just also added some DGAs into the register. If this is not working, the doctor has certain pharmacomolecules to give adjunctive to the patient. But if all this is not working, then bariatric surgery comes in place. And there are different surgery methods. But the question is why we need to let it so far. Why we don't intervene early before? Why these interventions before the prevention is not working? And here's the failure. Most of the therapies are not long enough. Mostly they don't have the long follow-up time. The patient is not guided for a longer period. And as I told you, obesity is a slow progressing chronic disease, so the patient also needs continuously monitoring for a longer period. And mainly interdisciplinary support is lacking. So in particular the behavioral support, which usually is not addressed. And in this way, these therapies are not sustainable. And also, which is not addressed, the individual patient. So each patient has an individual need, and this is not addressed by those therapies. But with our digital advancements, it actually raises the question, may this digital intervention solve the obesity crisis? And I show you here a graph, and you clearly see that the usage of mobile health intervention is increasing. And there is an exponential increase over the years, in particular mobile health applications regarding fitness, diet, health management, making over 50%. But can we use them as a therapeutic intervention? Well, yes, we can, and they may have the potential, but also caution is advised, because most of those interventions or applications lack scientific evidence. Most of them are unregulated and untested, so it might be different for the patient to discern which mobile intervention is actually generally reliable, accurate, and also sustainable. Also, data security is a big issue. And also, in particular, the personalization. To maximize the benefits of such intervention, personalization is needed. But what means digital personalization? Well, digital personalization means that different data from different entries flowing in together into one big digital platform. And we have this one platform, the phenotypic platform, meaning anthropometric, clinical data. Data we gather from our smartwatches, from our Internet of Things. And data we can gather from our biofluids. And measuring genetic background, proteins, our metabolism, the microbiota plays an important role. And everything flows together. And here, AI and machine learning come into place. Then we need AI and machine learning actually to fuse all this data together, and also that all this big data gets handled pretty well. And the output should be a personalized treatment plan. Sounds good, or? And how this might look like is the quantified self. Do you have heard about the quantified self? Actually, we are already starting to quantify ourselves. If you're like me, wearing an Apple Watch or a Garmin or a Fitbit, yes, you're quantifying yourself. You're checking your health, your own baseline. And this describes the quantified self. And how the future might look like, I hope not like this, like in the picture, that we need to wear 5 different smartwatches or 5 different sensors. So let me give you an example. You look in the morning in the bathroom mirror, and your eyes are maybe groggy, disheveled, and bleary-eyed. So maybe that will happen tomorrow morning after the event at the Felix restaurant. But there's another you, and it might be the future. The you is numeric, quantified, and displayed, actually along of illuminated data. And your smartwatch tells you the statistics. It will tell you the time you spend sleeping. In particular, you spend sleeping in deep sleep, in REM sleep, and in light sleep. It will also tell you your skin temperature and your emotional arousal based on the activity of your sweat glands. It also gives you information about your blood pressure and your oxygenation, and also your heart rate. In addition, you will wear a chip beneath your skin, and this chip will tell you some other biomarkers, like your glycemia, your stress level based on your cortisol, the ketones, cholesterol, and the inflammatory level. And in addition, you have the possibility to make a prick in your finger and put one blood drop on a sensor. And this sensor will analyze again some other biomarkers. And either the sensor turns blue, so meaning everything will be fine, or turns red, meaning there is a failure. There's something abnormal. And this is also the future. Michael Snyder, you may have heard of him, he's the director of the Center of Genomics and Personalized Medicine at Stanford, wants for everyone in the future. And Michael Snyder, actually, he's the best example. He did this everything. He was building up a whole Snyder roam around him. In the morning, he gets up, starts wearing 3 smartwatches, he's tracking his sleep, and he has a continuous glucose monitor, a sensor, and he's checking his health all the time. And also he built it up with his own lab, a big data platform about his genome, about his transcripts and his metabolites. Sorry. So, but how we can gather this data? And this is what he described, or was described in one of his last papers in his lab. So this paper describes what the advantage actually is of this continuously monitoring. And he describes how we can measure thousands of metabolites and lipids and inflammatory biomarkers from just 10 microliters of blood, alongside some other physiological parameters gathered by our smartwatches and sensors. So, this sounds actually pretty good, in particular for obese patients, to specialize this treatment plan along the physiological responses to a certain diet, to an exercise regime. But there is one pillar still missing, and that's the behavior. But how we can incorporate now in a personalized therapeutic plan the behavior. And you may have heard of the behaviors intervention technologies, BITS. That are these notifications, messages, AI-powered, personalized text messages you receive on your smartphone. And they're important, they are crucial, and they align with the nudge theory. Did you heard about the nudge theory? You might be familiar. Yes, the nudge theory actually is involved, or nudging is involved, and decides which choices we are doing each day. Do you decline a chocolate at the train or at Swiss Air? How do you decide your food when you go in the cafeteria? These are all nudges. And nudges we can use to actually support a patient during these therapies. And in particular, one example are GTAs. GTAs are just-in-time adaptive interventions. So they are like a digital companion or digital buddy. So giving personalized feedback and response to a certain behavior. And it was shown already in several publications, but I want to show you one example from a Swedish study showing how they used just-in-time adaptive interventions in patients with type 2 diabetes. And indeed, they were successful that these patients improved their exercise and moved around during the day. Another successful study, it was about the Health React server, and this server gives patient personalized feedback depending on data gathered on the Fitbit. So there are a lot of more examples I can tell you here, but there's another question I still want to ask you. Is too much being promised with this digital intervention and digital possibilities we have? And yeah, although there are a lot of advances have been made, we have still some barriers. And there was a study performed by McKinsey in 2021, and McKinsey asked patients as well as healthcare providers or practitioners about the efficacy of such digital interventions. Most of the patients said they have been kind of convenient. They had showed an improved experience. Most of the physicians, on the other hand, they have not been convinced by the efficacy of telehealth. So meaning there is still a lot to do. And there are some other barriers concerning technological issues. I don't want to go in detail, but I think you are all aware of that. And also one other point, and that's the socioeconomic status. But finally, in coming to the end, ask you, and we can discuss it later, has the future already arrived? Or are we already there? And I think we are close. So we can gather deep and a lot of phenotypic data. We can have the possibility to perform multi-omics approaches on a wide scale. We already adapted AI and machine learning in our daily lives. We are already able to cluster certain patients and disease groups and give cluster-specific recommendations, like for obesity, for type 2 diabetes, and so on. But we are not able to make individualized recommendations. And here's the problem. And I'm a scientist, I'm a researcher, and I know that trials with just one proband, also N of 1 trials, are not evidence-based. But that's the future, and that is what we need to perform to give really personalized guidance. And also, what is also important to make this continuous measurements, to check or acquire knowledge of our own baseline health. And this we will be able to do with sensors. Sensors measuring our physiological state all the time. And finishing just with one sentence. Our healthcare system at the moment is still focused on treating diseases. But it should be focused on maintaining and improving the health. But at first we need to define health, in particular on a personalized level. So, and I thank you for your attention, and I'm happy to answer you questions afterwards or tonight. Thank you very much.
Thank you so much for sharing those insights. Maybe one quick question. This chip you were talking about, is there already a prototype or a product on the market which you can use?
I know a lot of companies and people in labs working on that. So it's not available at the moment. I think glucose meters, ketones, cholesterol you can measure pretty easily. But if you're going deeper, in particular looking at inflammatory markers, in particular in a non-invasive way, it's not on the market at the moment.
So we still need to wait a little bit.
Exactly.
Thank you so much.
Thank you.
So let's get the next speaker, and this is Andreas Bollmann so far. Yes, I see at least your slides here. So jump on the stage and Andreas, you're a cardiologist, so I think many things which were touched upon today are also part of your daily business. So your work as a managing director at Helios Health Institute, which you can also explain what you're doing there, which was also the Heart Center at Leipzig. So welcome on the stage and just give us your talk.
Thank you very much. Can you hear me? Is it on? Good. Awesome. So yeah, I have two jobs actually. I'm a cardiologist at a heart center. I'm most of the time treating patients with cardiac arrhythmias. And my second job is I'm the managing director of the Helios Health Institute, which is the research organization for the Helios group. So, and I can invite you to both institutions for like 10-15 minutes, show you what is going on at the Heart Center and the Helios Health Institute with respect to outpatient and digital care. So, before we start, we need to review two legal documents. One is on daycare operations. And what you see here is the procedures we usually do in an inpatient setting. So patients come to the hospital, get their procedure done, and then they go home after 1 or 2 days. The yellow marked procedures, they need to be done in a daycare setting, in an ambulatory care setting. And that is all implantable pacemakers, basically, that you put in on an elective basis, and all generator replacements. And the surprising thing is that started April 1st of this year. While this is not a big medical procedure, so in routine hands, it can be done in 30 minutes, the real problem, and we come to that in a second, is the logistics behind it. How do you do that in a hospital setting? The other thing, and I don't have an English translation here, so the Krankenhauspflege-Entlastungsgesetz, I'm having a hard time reading it in German, tells you a lot about the future of healthcare in Germany, and those are some of the items, and I'm not an expert in Hebammenversorgung, so I will talk about cardiology and what we can do here, and focus a little bit on daycare procedures and telemedicine. This is our CEO, Robert Möller, CEO of Helios Hospitals, and he says, yeah, sure, at Helios we can do it. So we will make it possible that we have all the procedures done in an outpatient setting. And you have to think about it for a second. We are talking about all procedures that are done in a hospital that now, with this new law, can be done in an outpatient setting. So you name it, every procedure you can think of could, in theory, be done. I will focus a little bit on cardiovascular medicine, and here are some data worldwide that showed it. So are we the first in Germany? Apparently not. This is daycare for coronary artery disease, so atherosclerosis of the heart, basically, where usually the cardiologist puts in a stent. It's called PCI, and you see that here, and on the upper level, on the upper bar graph, you see the increase of this procedure being done in the US in an outpatient setting. You notice something else, and this is the range, the variability of this graph. So it ranges from 0% to 100%. So there are centers who don't do it at all, and others do it all the time. On the lower graph, you see two things, one in blue, one in red. And this is how you approach the heart. You can do that either via the groin, or you can do it via the hand. And the hand is in red here. And of course, if you do it from the hand, the patient can walk freely afterwards, doesn't lay in bed afterwards, and you make this procedure easier, less complex, less invasive if you do it from the hand. It's the standard approach, and if you do it that way, the percentage of daycare procedures goes up. Same data from England here, so color coded. The darker the colors, the more of the procedures are being done in an outpatient settings, and you see two things. Number one, the darker colors, the more the daycare procedures increase over time. At the same time, you also see the huge heterogeneity within the country. So some centers do it, others don't. Now, TAVI, another fantastic procedure, you may have heard of this. This is implanting a cardiac valve via a catheter from the groin. So it's unbelievable complex. Usually patients or stay in the hospital for 10 days, 10 days in Germany. Can you do that in an ambulatory setting? Well, if you follow this so-called Vancouver 3M path, which is multidisciplinary, modal, and minimalistic, apparently you can. In 6% of the patients. 6% of the patients go home after this very complex procedure. Another procedure is occlusion of some parts of the left atrium. You see the same thing. There's more procedures of this kind being done in an outpatient setting, but you also see the heterogeneity. Some centers do it, others don't. Same things for atrial fibrillation. It's data from Canada, where it is a standard procedure and being done in an outpatient setting. Now, how do you do that? If you want to implement this, you have to think about patient characteristics. You want to really identify the ideal candidates for this procedure. You need to have a minimalistic approach. That means less catheters, less exercise, and so on. Yep. Then you should standardize your path. So this is very important, that you standardize the patient flow within the hospital, pre-interventionally, during the intervention, and afterwards. And of course, and this is the main topic of today and the whole conference, you need to use digital tools, clinical decision support, and apps to follow the patients. While you have seen that this is medically not that tricky, it can be done. I think the most important thing is the infrastructure and logistics. So how do you manage the patients before the procedure, during the procedure, and then afterwards? Now, this is a study project that we are doing. This is very interesting for exactly this reason. The Heart Center in Leipzig is a center that treats patients from all over Germany. This is shown here for a particular procedure, the ablation of atrial fibrillation. This is the procedure I'm doing most of the time. And you see two things. Number one, during the pandemic, and this is on the right-hand side, during the pandemic, the distance the patients traveled to see us at the Heart Center decreased from 150 to 120 kilometers on average. You see that down in the table. Yeah, it decreased. But at the same time, this is a very important number. Patients travel on average 120 kilometers to see us at the Heart Center for this particular procedure. Which means, well, you need to think how to get the patient to the hospital, what happens afterwards, if you are done with the procedure, can you go back? Well, we talk about that in a second. Let me briefly show you some of the things that I have in my hands every day. There are different tools to do this type of procedure, the ablation of atrial fibrillation. You can do that with radio frequency. You can do that with balloons that you stick in the pulmonary veins, the lung veins, where this arrhythmia usually happens. You can use cryo, which is cooling down killing the cells by cooling them down. You can use radio frequency or laser. And this is a new kit on the block. It's called pulse field ablation. It's a non-thermic energy. This is a very important thing. What do you do after the procedure? How do you manage the groin? So the patient needs to get catheters in. They need to come out. What do you do afterwards? Usually, this was a couple of years ago, the patient had these bandages and were lying in bed for 6 hours. Now you can use sutures, which has many advantages to close this puncture site, or you have new technologies, occluding systems that help you closing the puncture site. This is a pathway for a patient, how it could look like. So the patient comes in, has a very minimalistic procedure, it takes 1 to 2 hours. Then there is this closure device for the access site. Patient stays in bed for like 3 hours, gets up, and then can be discharged home. But how do you manage that? And those are the 3 protocols from different institutions in the US. And you see that you monitor the patient usually for 6 hours, which is a normal thing. But then, again, the distance to the patient's home seems to be of importance. And remember, 120 kilometers on average. Here they say they need to live within reach of the hospital within 30 minutes or 75 miles. Now, what helps you in the patient management? And this is telemedicine. So everybody's talking that. That's the reality that we are seeing at the Heart Center these days in our department. We see an increase in the number of consultations, the days we do this telemedicine, and a sharp increase in the number of cases. So in a month we do like 100 to 120 teleconsultations with the patients before they come to the hospital. Yeah? And this has a very interesting effect. Not only are the patients better prepared when they come to the hospital, we are better prepared when the patient comes to the hospital, but also, and this is the thing I want to point out here, the gray area, 33%, a third of the patients doesn't come to the hospital after the teleconsultation because there's no need to. So like last year, same time, they were all flocking into the hospital with all the administrative work, getting all the tests done. Now, everything is solved via telemedicine. This is a project I'm particularly proud of. This is a telemedicine app, research app that we are currently have developed and are currently testing that helps us getting 2 things. Number 1, biodata. We focus on the ECG as a cardiologist. And not only is it transmitted to our center, we have also built a telemedicine platform where you can analyze the data and send the report back to the patient. And the second thing this app does, we can collect so-called PROMs, patient-reported outcomes. So basically questionnaires about the health of the patient. This is standardized, and you can get a quick overview of on how the patient feels. Now, what do the patients think about the whole thing? Those are patient preferences. We asked, how does it look? Are you interested in same-day discharge? And 50%, so another factor to take into consideration, 50% of the patients said, yeah, that's a great idea, let's do it in an ambulatory setting. We talk a lot about digital health, and we heard about the apps. What do the patients think about that? You see heart failure and atrial fibrillation panels. So heart failure is a dysfunction of the heart. Basically, the heart doesn't fill or pump in a correct way. Usually those patients are a little bit older, so 69. 70% said they're not interested in any digital follow-up. Looks a little bit better if you go to the AF ablation or the AF cohort, which is in generally a little bit younger. So now we're talking about mean age of 62. In those cases, 40% said no digital follow-up, or on a positive note, 60 said, yeah, let's do it. Yeah. Of course, we need to talk about AI, so we heard a little bit about that already. So in 2003, so 20 years ago exactly, almost to the date, we saw the rise of the machines. And if you look into the publication database, you see that this is really happening. You see a steep increase in publications about AI, machine learning, and all related fields in cardiology. So last year, more than 4,500 publications in this area. Yeah? So what can we do? And I focus here only because of my profession of the ECG specialist. I focus only on the ECG. This is a ECG that you may know and even had, some of you. It looks normal, but from this, I would say, yeah, that's good-looking ECG. Everything is fine, but with modern AI tools, we can see much, much more. So this is listed on the right, and I want to spare the details, but it tells you a lot of activities in the heart that are ongoing. Heart dysfunction, cardiac arrhythmias can be predicted from this normal-looking ECG. So how would that look like? This is look into the future. Those tools need to be implemented in in hospital information systems. And then on the upper board, you see the predictions of the algorithms for certain diseases. And I want to draw your attention to the right side, the probability of AF, so the probability of a certain cardiac arrhythmia occurring. In this case, the algorithm predicted it, and you probably don't see it in this table. This has been predicted months and years before the patient actually got it. Yeah, that's very important. Question is, and I think there's time to discuss this, what do you do with this information these days? So, and I think that's the same, same in your field. We are also heavily involved in this, active. We got a nice research grant where we study the ECG in order to, what can it tell us about catheter ablation. So, then one last word about ChatGPT. This is from Wall Street Journal from last week. AI, and this is the value proposition of us physicians. Yeah, we are so empathic. Yeah, the empathy is our last domain. But then, if you compare physician answers to chatbot answers to patient questions, you see two things. On the left-hand side, you see that the quality of the answer that the chatbot gave was rated higher than what the physicians did, and the empathy that's on the right-hand side, but also higher with the chatbot answer. There are many methods, many problems with the study with respect to methods. We can talk about that also, but it won't be long until this last domain is also gone. So, in summary, I think I made clear it's simple to do those or some of the procedures in an outpatient setting. It's very important to find the right patients based on patient characteristics, but also patient preferences, and you need to define the process for doing so. In that respect, telemedicine and other digital solutions will support that. And you need to really take care of addressing all different stakeholders. We have ongoing projects where we do this together with patient organizations, payers, and so forth. And then this is the future. So patient comes in to the outpatient setting and goes home the next day. And at the end, I asked ChatGPT to tell a joke. Unfortunately, it's in German, but most of you are from Germany. So this is what the one I liked most. Warum wollte die künstliche Intelligenz den Kardiologen daten? Weil sie sein Herz erobert hatte. Maybe funny, maybe not. I don't know. You have to judge. And I'm very proud of this picture that I made. Oh, actually not me, but Midjourney did it for me. This is the way the future may look like when they two find each other. Okay. And that concludes my presentation. Thank you.
So I'm looking forward to our discussion because I have many questions. Also to the audience, when you have questions, please keep them in mind because we only have one last presentation and then we will have a discussion where you can also raise your hand and also ask some questions or give your thoughts. So last but not least, Jan, it's your talk right now. So Jan Bigger is Senior Director Digital Ecosystems at GE EMEA. So let's see what's your moonshot here.
Laura, thank you very much. I hope you can hear me well. Perfect. How do you feel today? Last night we had a prep session in the evening. I just had, I think, one drink too much, so not tonight again. Look, thanks a lot for joining us here, and I think we have the better room. I mean, this dark room over there, this is much nicer from my perspective. Look, I'm with, Laura just mentioned this, I'm with GE Healthcare, a global medtech and diagnostics innovator, and I'm responsible here in Europe for primarily two things, partnerships, digital partnerships, and innovation. And in my daily work, I focus primarily on finding the right partners, bringing innovators and change makers together to work and build relevant digital solutions to drive the digital transformation of healthcare. This is one. And the second is to make sure that the solutions we build, right, we build with partners, we build in-house, are truly adopted in healthcare settings. Yeah, so I think this is something very important, and especially in this field of, which we have heard several times already this morning, in this field of artificial intelligence. And during the next couple of minutes, I would like to answer the question you can see here on the screen, why healthcare needs AI. And Andreas, you just mentioned a few things here, but I'll give you a couple of interesting examples. And look, I think we all know in healthcare there are a lot of, from a global perspective, there are a lot of challenges we face, but there are actually also a lot of opportunities to do things differently. Yeah? So we have seen a couple of numbers. Perry shared a couple of numbers. Dorothea, you shared a couple of numbers. I also have a couple of numbers to highlight those difficulties and challenges, but also talk about potential opportunities here. First of all, as you can see here on the screen, it just takes it just takes today about 72 days to double medical data. Right? I mean, just picture this. This is from today, like, I think, mid-late of July, if I'm not mistaken. There are 6,000 medical journals out there publishing 900,000 articles a year, right? Which means, for instance, for a dermatologist, they could read 11,000 scientific papers each and every year. The general practitioner, so your Hausarzt, would need to read for 21 hours each and every day to keep up with primary care literature. There is more information in a mammogram, which you can see here on screen, than there is in the telephone book of New York. Actually, I don't know if there is still like a physical telephone book, but I mean, this amount of information to deal with is just massive. And it's not uncommon that such a mammography image is about like 1 gigabyte in size. Actually, are there any radiologists here in the room? Just checking. Great. It's not. So, look, I mean, I'm saying this because the person here, radiologists usually, I think that's an AI-generated image. Issue here is that your chest X-ray, right, which the person reviews, is just turned upside down, so nobody would read an image like this. But what I want to show you here is the pure fact that in a 12-hour shift, the radiologist today, on average, reviews 50,000 images, compared to like just 500 about 15 years ago. And there's been this explosion of data, and we heard about this earlier on. We know this in our everyday lives. There is this explosion of data we have to deal with, and so in healthcare, with really no end in sight. And look, perhaps, right, when I talk about radiology just right now, perhaps one of the reasons why there are so many images in medical imaging is the fact that radiologists usually take 2 images of the human body, right? So of 2 different directions, AP and lateral, because this is very important to get to the correct diagnosis. So radiology, for instance, has over the last couple of years really moved from a subjective, perceptual skill really to an objective science. And actually, here on this picture, Prince William is right. There are only 3% of healthcare data which is really used to generate really actual insights. There are 97% of our healthcare data just sitting there untouched, unleveraged, unharnessed. And today, this sheer mass of data, this treasure is just a cost and does nothing to improve quality and efficiency. Something else. Globally, there are around 40 million medical errors each and every year. And in Europe, it is estimated that up to 350,000 people die due to medical errors every year, which is like the population of Cordoba or Venice in Italy or Toulouse in France. Yeah, so massive. And for every 100 hospitalizations per year, approximately 14 adverse events occur. Next pressing topic I'm sure you're all aware of. The shortage of healthcare professionals. Globally, As of today, about 7 million. And in 2035, it is estimated that about 40 million healthcare professionals will be missing due to retirements and not enough young people entering the space. And in addition to this, we all know the demand is going up, complexity is increasing, care pathways become more and more complex, so it's just getting more challenging over time. So what I try to show you here is that things like access to healthcare, quality, efficiency, but also cost, are huge and growing problems at a global scale. And in addition to this, there is this digital data, right, which we have access to, which we sit on, which today is usually a challenge and cost, but it's also a huge opportunity. And I hope you agree to this. And I think harnessing this data differently, right, and really leverage it, right, get to better outcomes, better solutions, I think will be core to the future of healthcare going forward. Because AI can create better data, better quality, and hopefully, right, we heard this a little bit earlier on, also find ways to free up valuable time of healthcare professionals to spend more time with patients. So look, the radiologist I use in my example today is actually a scarce resource. Demand and access to high-quality radiology diagnostic services is increasing at a global scale, and the industry is working to tackle parts of that problem with technologies such as artificial intelligence. Yeah? And in terms of AI adoption, in healthcare, radiology over the last couple of years has been at the forefront. And therefore, I would like to show you a couple of, let's say, AI use case examples in the medical imaging domain. Here you can see a mobile X-ray machine. Yeah? So something that is used in the emergency room, at wards, in the patient's room, to do simple X-ray imaging. A machine which is right, easily movable from one location to another, especially right to the patient's bedside, where you don't usually have access to large or more, let's say, fancy, advanced imaging equipment. What we have done here is we have added a suite of AI solutions onto the machine to help with things like image quality. Yeah? I mean, patients in their bed are usually difficult to X-ray, so we help with AI here, also to help positioning the patient, improving the image overall quality. And it also helps with detecting potentially, let's say, critical conditions, right? So in some parts of the world, in Germany, we don't have an issue so much, but often you don't have not easy access and fast access to a radiologist, like the medical doctor. So you take the image and the machine can tell you, hey, there is a critical condition, for instance, a pneumothorax, let's say, right? And the machine can tell you, hey, there is a high likelihood of something like this. You should do something about it, right? So this is what we do as well. Endotracheal tube placements is something I think a radiologist is overtrained for. Didn't go to medical school to do this each and every day. So this is also what AI and the machine can do today. Another quick example. Here you can see ultrasound. Yeah, ultrasound, a highly effective diagnostic tool, but the tool's, let's say, effectiveness highly depends on the user, right? On the operator skills, which actually requires quite specialized training. And mastering this kind of technology requires, right, this type of education, which usually spends a couple of years. And even if you are able to produce high-quality images, the comparability over time can vary quite significantly, always depending on how the operator uses the probe or the transducer. So, and this kind of execution of those exams, usually I have a small handheld ultrasound device with me, requires like a unique kind of blend of hand-eye movement and also interpretation of quite complex visuals. And traditional ultrasound software does not help with that. It lacks like guidance and real-time feedback for the user. And I mean, this is the reason why we at G Healthcare, for instance, just recently acquired a California-based company called Caption Health. And what they do is they help in real time guide users, even inexperienced users, to do ultrasound properly, to get to the right images, to the right image quality. It even does things like automatically measuring ejection fraction, for instance, right, an important heart measure. So automizing this, and with this allowing ultrasound technology, right, get into, let's say, broad adoption also for, let's say, more or less unexperienced users. Another quick example in MRI. So, I mean, here what we have been doing a couple of years back is putting a deep learning-based reconstruction algorithm into our MRI machines to improve the so-called signal-to-noise ratio, improve image sharpness, and most importantly as well, shorten scan times. Yeah, so make this examination where you are put in this kind of tube, right, which is not that fun. Make it shorter, so overall the patient experience is improved. And by leveraging here the MRI raw data, we are able to, right, on average, like reduce the scan time by 50%. And you can imagine this is quite a huge difference. Now here just another set of images, and in the middle you can see this AI-powered image, and on the right-hand side what kind of noise and ringing has been removed. So, I'm talking here today a bit about the radiologist, which is a, let's say, domain in healthcare, a profession that is like digital since more than 15 years. Yeah, so radiologists sit in front of their screens in their usually dark room. They use voice recognition to create their reports. So what I'm saying is the diagnostic reporting workflow is pretty streamlined. And now what we see is that those AI technologies come into reality, into their work. So-called AI decision support tools, really transforming the domain of radiology, automating image analysis to some extent, improving diagnostic accuracy, and reducing also the workload for radiologists. And there is one interesting problem we as an industry now have to deal with, and this is not building more AI algorithms. Yes, we do this, and I tell you why as well. But how can we make sure that those new technologies are seamlessly integrated into existing workflows? Yeah? Because ultimately what we want to achieve with those technologies is to get to more efficiency, better productivity, better quality. Yeah? But if we like force a user, the radiologist in my case, to learn a new user interface, right, to do additional manual clicks beside his regular streamlined workflow, will not get to acceptance. And I think this integration of AI from different vendors, startups, larger companies, ones that are built in-house in my university hospital, so how can I make sure they are deeply integrated into those existing workflows? So reality is today, and here just a snapshot, in Europe there are about 200 AI algorithms available for radiology decision support that you can basically get today. Yeah? So commercially available means they have a CE mark, and you can use them in your day-to-day clinical settings. Those different algorithms, those products, 200, a bit more like 200, are coming from 90 different vendors. Yeah? And all of those vendors, of course, you can imagine, I mean, some of you are also in like digital startup companies and so on. All of those different vendors have a different approach to user interface design, user experience, and this is what I'm saying. We have to do something here to really seamlessly integrate to make sure that algorithms such as the detection of lung nodules, the diagnosis of brain tumors, fracture detection, and so on and so forth, all those narrow and very niche and specific algorithms are really tightly integrated into existing solutions. And this is really what I wanted to show you here, right? It's not just about building AI, this is super important, but it's also important to think about how can we make sure that those solutions, right, find their way into day-to-day clinical workflows. And I think this is something that only works when, right, different stakeholders in this ecosystem collaborate. Look, I talked the last couple of minutes quite a lot about radiology, and therefore I think now it's time, as you gain some radiology expertise, to do a little bit of a, let's say, skills assessment and attention check. So what you can see here is a study from like 10 years ago, and I don't know if you ever heard about what is called inattentional blindness. Or let me ask, do you see, is there something wrong with that patient's lung? Yeah? So look, what happened here was that a group of radiologists were asked to detect pulmonary nodules in images. And the last image, which I show you now here, was manipulated and a gorilla was added. That is 48 times larger than an average lung nodule or round focus. And believe it or not, and this is why I asked if there are radiologists here, 83% of radiologists did not see it. Yeah? Okay, let's move on. So who of you, and Andreas, you talked about ChatGPT just a second ago, who has not seen this screen so far? Or let me better ask, who has not used it so far? Yeah? ChatGPT, I think we all have read about it, heard about it, the so-called large language model, generative AI, designed to understand like, or generate human-like text, enabling a variety of different, let's say, applications, and can assist in a variety of different domains. And look, innovators around the world are now looking into potential healthcare use cases, right? And there are plenty of those. And before I show you 3 of them, I just want to point out one thing in our industry, which is very important, right? And some people argue, hey, this is like slowing down innovation in the field. But everything what we do in our space, especially in this broad field of digital health, we need to make sure it's ethical, it's validated, right? The things we put into in front of patients and healthcare professionals actually work. So upholding these kind of principles, right? Data privacy, minimizing bias in AI, ensuring rigorous validation, upholding these principles leads to like safe, accurate, and equitable healthcare outcomes for us. So this is very important, and I think this kind of ChatGPT type of technologies, large language models, or generative AI overall, will come into our domain. But right, we as an industry have to be careful that this actually really works. We make sure it really works. So just like 3 interesting use cases I've seen the last couple of weeks. You know, the development in that space is just mind-boggling. Here you can see a guy called Clifford Stormer. He is a rheumatologist in the US, and he uses ChatGPT since it came out to help with and to deal with insurance deniers. So that means usually, yeah, he sits down, he writes a letter, put references to that letter, he sends that to the insurance company to describe why his patient needs a certain test. Yeah? And now, I mean, ChatGPT does it for him. Yeah? So pretty much automated, right? You could question now, hey, what about patient data? But, and of course, that's a relevant question, but this is a good example of, right, how to kind of mundane, repetitive tasks can be taken over by technology. Another interesting example from like 3-4 weeks ago, Varun Shenoy, he's a young student at Stanford, connected ChatGPT to the health app on his iPhone, and now can have like conversations with his digital health history. Also a pretty impressive case, actually. But the most interesting in my world was the one I can show you here, and there's a video to this. So if you want to just, I don't know, connect on LinkedIn, I can send you all this. I mean, imagine you go to your hospital, ask for like a printout of your medical record, right? Hundreds of pages of lab results, unstructured, handwritten, untidy handwritten notes. Right, put this to ChatGPT and you get or a large language model, and get a structured overview about your patient history. Just imagine what we can do with this. As an industry, over the last couple of years, we have invested a lot in work in terms of how can we input data in a structured manner into our systems, right? So the question is this still required, or just will we ever get there, or is this not something like this not the better way? And look, I mean, I showed you earlier on a couple of examples of computer vision, image recognition, right, in radiology. Here we see now examples of how text, right, and unstructured data is analyzed by AI. What if we could bring this together? Yeah, I mean, just imagine this. If we can bring those worlds together on one hand side, if you have a patient with kind of images, cardiology imaging, ultrasound, dermatology, ophthalmology, whatever, right? Let this analyzed by such kind of computer vision algorithms, and then all the textual data and unstructured data can be analyzed by such large language models. And really, this combination is extremely powerful, and I think a lot of researchers, companies over the globe are now looking into this to make actually this happen. Look, jumping to this page now, do you see, right, any difference between those two classes? I mean, pretty simple. One contains cold and one contains hot water. We as human beings cannot see this, right, at a glance. And I think this is a good and a nice symbol for AI. With artificial intelligence, we can really harness new and additional capabilities, and in combination with our own skills, experience, and empathy, Andreas, yeah, it can really help us improve procedures, diagnosis, therapy, and so on. So look, I want to come to the end of my talk today, and try to answer this initial question, right? And now I'm a bit challenged by the paper Andreas shared, but look, healthcare is a people business. Yeah, we all know this. It's a human touch business, and it needs this human touch. And I think healthcare can greatly benefit from technologies such as AI, plus the combination of human expertise and empathy. Yeah? And I think AI in healthcare, we probably all agree, can automate a lot of like routine and mundane tasks and can free up valuable time. It allows healthcare providers, hopefully, to spend more time with their patients, delivering this human touch, which is so essential in healthcare, and actually also something where a lot of healthcare professionals find very rewarding and an impactful part of their work. So look, we at G Healthcare are really driven by our purpose, which is to create a world where healthcare has no limits. Together with a lot of partners, healthcare institutions, companies, startups, technology companies, we digitize healthcare, we drive productivity improvements for the lives of our patients, we create meaningful efficiencies for providers, health systems, and researchers around the world. And actually, if you want to see how we envision the technology, AI, digital-powered future of healthcare, I recommend to have a look to this video. Ladies and gentlemen, from my perspective, few other industries are as complex, comprehensive, and fascinating as healthcare. Not sure if you agree, but thank you very much.
Thank you so much, Jan. Thank you for taking us a ride through radiology. And now I look if I still have a couple of minutes for having a discussion. That's perfect. So I would ask all the speakers to jump on the stage again, because we have some more time. In case you in the audience have a question or want to mention something, please feel free also to step directly to the microphone, which is in the center here at the room. But I think we also have a lot of topics to talk about. So first, Andreas, when you showed at the beginning at the first example of AI that in the ECGs, the AI can see something which a human can't see, I directly thought, okay, probably not the answer or the finding that many physicians would like to have. And at the end, then you also reported the part of empathy. So how do you discuss with your colleagues about this?
what you have to do is, and this is a talk I had last week, you have to define a new task for the physician. So this is exactly what it's all about, because it will not run automatically by itself. So this is, I think we all agree on that, at least as long as I will be in in my profession. So what is it that you can do? You have to find the right use cases. You have to develop the models. You have to validate the models. You have to even start with validating the data first. So, and then it's all about implementing this in the ecosystem. This has been mentioned. Yeah, how do you do that and integrate it into your workflow? And the most important question hasn't been answered yet. So what do you do with these predictions? Yeah, this is you see something and then you say, okay, let's wait until it really happens. So there must be studies doing exactly this. So how to change the way you treat people these days. So you have to compare this new type of strategy to usual care, yeah, and standard care. And so there will be a lot of different tasks, but they will change. That's for sure.
That's good to hear. I think you're still in a profession where you at least have your surgery part. So let's wait until the robots take over this one. But maybe also another point here. At Helios, you also have the Helios Cube, which I think also is part of the bus tour, which we have here. So do you also translate these kind of treatment opportunities also to the Cube?
Yeah, so that's the vision, yeah. So you will probably hear about this in the next session. Enrico Jentsch is giving a talk there and probably will mention this as well. And you're all invited to come to the Cube tomorrow afternoon. So just in brief, it's a very Cube, as the name implies, so it's a healthcare facility that allows limited assessments. Yeah. So what you can imagine is that patients go there. There may be a nurse or maybe not, but then you have these fantastic opportunities you mentioned with the new test that you do with a finger prick, so one drop of blood, and you get like 1,000 of lab results. We heard about self-assessed or self-driven echo machine, so why not give it to a patient? See if he can make an echo by himself, yeah. And all this needs to be, as I said before, needs to be tested first. Is it really possible to do that? What does it mean, and how do you implement it? But that's the way we are thinking about the future. Yeah.
So the session is called Moonshots. So I was looking for a lot of moonshots here in your talks, and sometimes, as Jan mentioned, healthcare is one of the most complex industries. So I think one of the moonshot aspects is also bringing this one to patients. So if you have invented a new technology and then you also make it to the market. So I was wondering, maybe Doro, if you mentioned that your associations directly included DIGAs as in their guidelines for treating patients. So do you think that's the real moonshot to make people using these technologies?
I think that's a question to you.
Okay. I hope so, right? Because of course the DIGA market is big, right? And to get such applications onto the market, onto the patient, needs to be a DIGA. But for some cases, and also it's a case for for one of my startups, we don't want to become a DIGA, because our app, or what we develop, our product, is for people with eating disorders. In particular, eating disorders also highly stigmatized, and the patients don't go to the doctor on first hand, because then there is the result. You know, the employee knows about it, and it's a kind of shame, and it's a stigmatization with it. So we want to have that the patient gets the treatment or the support for himself, and not, you know, that nobody else knows about it.
Ask ChatGPT to prescribe it.
Exactly, more or less. So, and also, it's a difficult question to answer, actually. So, because it's a new market, and we don't know if it's really advantage to have these DIGAs coming up, or does a good intervention really needs to be a DIGA? So, yeah.
I have a pretty clear opinion about this. I think DIGA is not the wrong way, because I think DIGA is still an old way of thinking. DIGA helps you if you have a diagnosis, on the one hand, and giving an easy example from orthopedics. If you have pain, if you have knee pain and you have a diagnosis of knee pain, then it will help you. But what happens all of a sudden if your knee pain develops into back pain? Yeah, and we know, for example, that pain patients develop different syndromes, complex syndromes, and this is something that the DIGA cannot produce and cover. And it's the same when we use something or when we deal with psychological origins diseases. You have to look at the whole individual. That's what I showed. It's like this whole idea of 4P medicine. DIGA only always covers one very small aspect, and it is rarely able, or it will not for a long time be able to cover the whole problem. So I think you limit yourself. I think it's a way to start, but it's not where we should stop.
It's a good point that you bring up, right? It also lacks this personalization, because to get a DIGA, you need to have the studies, the evidence-based. But like I said also in my talk, right, the evidence-based is currently a whole group, a cluster of people, but not a trial of one. So it lacks really the personalization. And also, like you said or mentioned, that DIGAs are just prescribed for a certain time. And when we have our chronic diseases, it needs to take longer, right? They need to have a follow-up, a daily treatment, a daily companion who follows them for 1, 2, 3 years or more.
So Jan, you work for a global company, US-based. When you come to Germany, and then keeping in mind that you're also active in many other markets, how do you compare it? Is it easier to start a new Moonshot somewhere else, or is Germany the go-to place?
I mean, do you want me to be honest?
Sure.
It's difficult, right? I mean, I don't know if it's a cultural thing, but especially when we come up with, I mean, maybe look, to give you one example, what we do a lot is to go to hospitals, spend time with them and try to figure out what are the most pressing problems in your day-to-day healthcare delivery. And based on this, right, if this hospital is interested, we join forces, get together, find the right partners, such as like digital health startups, and work together with them to develop a prototype or just a concept or an idea, right, or even get it to a product at some point. And this kind of interest to collaborate, to work together, to invest manpower and capacity to change the status quo is something which we see a lot happening, and a huge interest, for instance, in the UK NHS, where I think you all know this from the news. There's a lot of pressure on that health system, right? A workforce shortage is a big gap, but those NHS trusts, those hospitals are still interested to change the status quo, right? They want to do it now. They want to get involved. They want to help. And this is like a type of mindset and culture, just from my perspective, unfortunately, in Germany, we don't have enough of.
Andreas, do you want to comment that?
Well, first of all, I share this view, but maybe we can discuss how to do it within the Helios universe during coffee or beer or wine later on.
Yeah.
So, thank you very much. So for the final round, I would like to ask you when we will see the next Moonshot in digital health. So just drop a number. So at which year do you expect something big? And I will start with you, Doro.
Ladies first, right? I would say, well, we see already the big advancements and the fast advancement, right? When we discovered or sequenced the first human genome, and now what we know now and how deep we can look inside a cell, it's just impressive also to me. And it's speeding up from year to year. And also I hope that soon we will able, like say, 5 years to make really personalized medicine. so max 5 years, you know, to get our sensors to get individualized and personalized medicines. Yeah.
So Robert, 5 years to personalized medicine.
I think Dorothea said it, since there is an exponential growth, it could be within the next 24 months. I think nobody expected ChatGPT to make that influence, and all the other AI projects to come up like that. So I actually think it would be faster probably. I think within the next 18 to 24 months, I think there will be next steps towards the ultimate goal, whichever that is.
So no pressure on the innovators. What's your prediction?
Look, I don't tell you a date, but so technology is there, right? I mean, we have a lot of technologies. We just talked a little bit about AI today as one example, which can make a massive change, right? A positive change in healthcare overall, moving really this, what we call healthcare today, which actually is sick care, to more prevention and what you talked about. So the technology is there. The one thing that is good that we have it is the fact that we're in a highly regulated industry, right? Where all the technology bits and pieces we implement, we need to make sure they work well, they are validated, and so on and so forth. And therefore, the innovation that is happening in other less regulated industries, right, or has happened already, is something we need to get to over time. And maybe this like regulatory side of things takes the most of the time because, as I said, the technology is there. So hopefully on that side of things we make progress, right? We improve regulations, we are able to find new ways to do like trials and tests and so on, and speed up this entire process to get this, I mean, impressive technologies also into the healthcare space as quickly as possible.
And now your date.
Yeah, so at least I'm not the pessimist here, good. No, not the only one. So what you said is, I don't want to repeat it, but this does not only apply to the technologies. I've shown it also applies for process and procedures and everything. So we can do it. But regulation, administration, I think that's a big issue. For instance, what I talked about, the ambulatory stuff, we can do it, sure. And during the pandemic, by the way, we have done it because there was shortage of beds, and then the morning you had a bed, the next day it was closed due to COVID. So we had to send the patient home, yeah. But we didn't get reimbursed for that. And I highly doubt that this will be solved quickly. So how do you do that? Yeah, how do you, for instance, the self-learning algorithm. So what do you do with that? You have the CE mark, but then you get new data. So how do you handle this? And there are so many. That's just one example. There's so many unanswered questions. The technology is there. It can be implemented tomorrow. But to get there in Germany, if you focus on Germany, this will be a long time.
Thank you so much. I think in the evening we will have a party to catch up with the 108 bottles of beer we have to get every year to stay on average. Thank you so much for taking the time, presenting your ideas and thoughts, and thank you so much for listening. Enjoy the conference and have a great time.